Hello, everyone, and welcome to Talk Nerdy. Today is Monday, October 28th, 2024, and I'm the host of the show, Dr. Cara Santa Maria. And as always, before we dive into this week's episode, I want to thank those of you who make Talk Nerdy possible. Remember, this show is and will always be 100% free to download, and the way we keep it going is by relying on the support of individuals just like you. If you'd like to pledge your support on an episodic basis, all you need to do is visit patreon.com/talknerdy. This week's top patrons include Anu Bharavaj, Daniel Lang, David J.E. Smith, Mary Neva, Brian Holden, David Compton, Gabrielle F. Jaramillo, Joe Wilkinson, Joseph Lamore, Pasquale Gelati, Rika Maharaj, and Ulrika Hagman. Thank you all so much. All right, let's get into it. So this week I had the opportunity to speak with Dr. Fazlur Rahman. He is a medical oncologist who was born and raised in what is now Bangladesh, and he was trained in medicine between Dhaka, New York, and Houston, after which he practiced cancer medicine for 35 years in San Angelo, Texas. He's also an adjunct professor of biology, medical humanities, and ethics at Angelo State University and has written for several different publications. He's got a new book out. It's called Our Connected Lives: Caring for Cancer Patients in Rural Texas. So without any further ado, here he is, Dr. Fazlur Rahman. Well, Fazlur, thank you so much for joining me today.
Thank you for having me, Cara.
I am looking forward to learning all about you and to really diving deep into your new book. It's called Our Connected Lives: Caring for Cancer Patients in Rural Texas. So, part of the reason that I was excited to have you on the show is because of the intersection of our interests. And I also feel like there's so much that I can learn from you. So I am from Texas. You are not from Texas. You were originally born and raised in Bangladesh, but how long have you been in Texas now?
49 years.
49 years. This is home for sure.
Well, between Houston and San Angelo,
Nice. And so tell me about some of the positions that you've held. You said between Houston and San Angelo. Where have you worked and what was your role?
Actually, I was trained in the beginning in the New York, so in the Long Island Jewish Hospital and the Queens General. And after that, I came to Baylor College of Medicine in Houston for my residency and fellowship. So that's where I spent most of my time. And I did some research there on platelet functions, this and that. And then it's a kind of like a life trajectory. West Texas is the last place in my mind. But my mentor told me that you could stay at Baylor, but you will be one of 100. So I have a need. They have a big need in West Texas. Whole West Texas doesn't have any oncologist. And oncology, remember, it started in 1972, so it was a quite new specialty. And I finished in 1975, so that's when I came here in San Angelo. And then on top of that, he said I could keep you as an assistant professor, but I think if I remember, $18,000 salary, and of course, money was more valuable then. And then Ara, my wife, and I, we have already struggled before as students, both in New York and Houston. And so he said that I couldn't raise your salary. That's not the way the medical school works. And you have to stay as an assistant professor 3-4 years before you get associate professor and more salary. So he knew all about me, Dr. Hettig. And so he suggested that I go to private practice. I always had an academic bent, so, and that will help you in both ways. You could help people. And what he said really most interesting was that you will be a pioneer, and there is something to be said about that. And you can make a difference. And kind of that really, my wife and I made up my mind after that maybe we can make a little difference somewhere.
At the time, you mentioned that you were studying academic, but also clinical oncology. Was most people who get their medical specialty is oncology, do hematology oncology. They do both. It sounded like you were working on research having to do with blood. Were you trained in both hematology and oncology?
Yes, I'm trained in both. I'm board certified in both.
Oh, okay. And so when you made the decision to get more of that clinical experience, when you made the decision to sort of move and work in these rural areas where it's harder for patients to have access, did you make the decision then to say, I will be a generalist oncologist? Or did you have certain specialties within cancer that you were hoping to kind of home in on and focus on?
No, I think medical oncology generally is a general medical oncology. And that's one of the reasons that I liked BCM, Baylor College of Medicine, because they had big hematology and big oncology wards, two big departments. And you could see all kinds of patients versus going to a cancer center. They have their place too. You tend to spend a lot of time in breast cancer or colon cancer or lung cancer. It is difficult to get that much experience, in 2, 3 years of fellowship or residency and all that. So that's one reason I stayed there. So I did want to be a general medical oncologist, so I could see all kinds of patients and all kinds of problems. Not that I would be an expert on all of them, but at least I could try.
That's interesting. I didn't really think about it that way, but that makes perfect sense. I actually do work in a cancer center, but I'm not an oncologist, I'm a psychologist. And so I have the opportunity to see different patients with all different types of cancer at all different stages. But you're right, the physicians are quite specialized where I work, and they see very similar types of cancer over and over and over.
Well, then I realized he and I have a lot of things in common. So that kind of made me happy that you asked me to come to your show. Probably in some
Absolutely.
respects we speak the same language.
Yeah, I feel like I have a lot to learn from you because you sort of you have that translational knowledge, the medical oncology sort of laboratory knowledge. You can read obviously all the articles, you understand the research, but you've been treating patients now for quite some time, and you've been treating patients from all walks of life in a rural setting, which is very different than where I work, which is a large cancer center in one of the biggest cities in the country. And so I would love to just sit with that for a few minutes and maybe we can dig deep into the experience. What are some of the differences when you are treating patients in a rural setting, and especially in a place like rural Texas?
You have to make a difference between, like, say, 50 years ago when I started practicing, oncology was quite different. Okay, we did not have good anti-nausea medications. We didn't have any good drugs. And one of the biggest difficulties was that you send patients. I'm not sure how familiar with the West Texas. People used to come from Alpine, Big Bend, and all those places, and among other things. And now there are oncologists in Midland, Odessa, and other places. But at that time, I was the only one all over West Texas. So you send someone home, and there are some general practitioners, and it is not their fault. They are not comfortable in taking care of cancer patients on chemotherapy. And so you worry about them, and they worry about you, how they will get hold of me. We didn't have any cell phone or any of those things before. So all the chemotherapy patients had my home number. And my wife, Ara, everybody calls her Ara. Her name is Jahanara, ARA. So she used to end up taking a lot of calls at night because usually that seems the way, like a lot of people get sick at night. So that's how they got hold of me, and that's how they contacted me when they needed any emergencies because of the phone. So you have to kind of tie it to phone at times. Things are quite different though 50 years later. It's much more sophisticated. You have cell phone, easy access internet. And remember, when I came here, 75, there was no cancer library. we have a university here. City was small, and they had a fairly good library, but not a cancer library. And you don't have any colleagues to talk to or anyone to share your doubts and problems, but you called your mentors, but you can only call them so many times and so much. So you do the best you can and you tell the patient, and then so that one problem, that is um, no library and no one to talk to. It's quite different now, it's more advanced. So that's one. And the second was that the access to the patient, just like you mentioned, rural patients tend to be elderly and they have a lot of comorbidities, for example, diabetes, hypertension, arthritis, cardiovascular problem, as happens in elderly people. And there was no good medical facilities in most places. And so they have to drive like 100 mile, 200 mile to come to see the doctor. And then there was problems like, I'm talking about the older days, still to some extent, screening program, this and that, they didn't have a whole lot of access. So those things add up. And a lot of rural patients are poorer too. So, but to answer your question about these, so these are some of the difficulties that I had to deal with, I had to circumvent, both for patients and me both. So eventually, things improved and drugs became better. You had good anti-nausea medications and you had more colleagues and others, much later. So those things help a lot. But eventually, it is always between you and the patient, and no matter what. And with due respect to your big center, like we all are trained in big centers. It's a little bit of a rarefied atmosphere, in the sense that, like if I may say so, my patients didn't have internists or family physicians, some of them, and not all of them, and many of them didn't. So if they wanted some blood pressure medicine prescription, I gave it. I didn't do anything that is beyond my competence, and you have to have internal medicine training before you can become an oncologist, and you have to be board certified by internal medicine too. So I had some training in internal medicine and all that all those years. So that helped. And once I got busy and other internist family physicians came, quite a few of them, then I kind of slowly concentrated on oncology only. But in the beginning, it was quite difficult. And it's kind of hard to explain to people because new trainees, I don't think would understand that. And just recently, I was reading an article by Dr. Devita and George Canellas that is saying that medical oncology probably had the hardest beginning of any specialty. But people would look at you with suspicion that you're just dispensing poisons, and a lot of doctors didn't feel comfortable with that. And many patients didn't either. I don't blame them. So those are some of the things that he had to deal with, and he had to understand it, and he had to feel your way into it. I mean, people live in West Texas. It's a little different now, but Houston or New York, they live quite differently. Or I think you are in LA, uh, than people live in West Texas. So um, they have different temperament in a way, and different understanding, and different way of dealing with life, because we can't just right now people can do that. They couldn't just go to here, buy something, buy there. So they have to plan all those things ahead of time, including coming to the doctor.
Yeah. Yeah. And different values, different ethics, different, you're right, different day to day rituals and experiences. And I think sometimes that's one of the most humbling things for young providers is that to engage with a patient and to affect change in a patient's life, it is not just regurgitating what we learned in textbooks, but it's to actually connect with the human being at their level, to adapt to their understanding, to take their frame and to work with them, at least attempt to see the world through their eyes as best we can, which can be a challenge, especially if you come from a different place or you have a different culture. I can imagine that Texas might have been a bit of a culture shock for you when you first got there.
Well, yeah, it was probably a lot of my friends in New York didn't encourage me to come to Texas, but I wanted to come a little bit in a warmer climate. I grew up in a tropical country, so and then Baylor College of Medicine. It was a tough place too, but they gave me a chance. So the chairman, Dr. McIntosh, he interviewed me thoroughly. So, and I've done some research on malabsorption due to abdominal tuberculosis when I was a student at Dhaka Medical College, and that helped me too. And so those are some of the things. So that gave me a chance there, and I did my best I could. I'm not sure I always succeeded. I've shared my share of failings, both in practice and both in training, but I did the best we could. And so that was good experience. You are right. You're talking about the different, like when I first came here, say 50 years ago.
Right. Those are both differences, right? Coming from New York to Texas is a big difference, but also 50 years ago to now is a big difference.
Yes. Well, the interesting thing is that when I came here, then you have to have consent from sign. Like a lot of employees want your information, this and that, but they used to call, commonly. And so they'll say, I need the information on this patient, he wants to take off work. And so I said, I don't have any permission or anything, so I couldn't give it to you. And then when my assistant or nurse called the patient, says, I tell you that go ahead, anybody calls, tell them. But
right.
that's not the way I was saying. Not anybody, I mean anyone from my office or my company calls, give them information. So that was something new to me. In Houston, in New York, we always, first thing we do, consent from sign, correct? And he said, well, I told you, isn't that enough? My word is enough.
Right. It's all word of mouth. That's so interesting.
They believe that, once you gave a word, so that means something. So that's enough. I don't have to sign anything.
Yeah, I mean, Texas is its own place, right? Texas has a culture and it has values, and it's not monolithic. So, of course, part of working with patients is getting to know them. It's getting to know where they're coming from, getting to understand their fears, getting to understand their reticence. And I'm just curious, I mean, how do you even encapsulate this in words? But my guess is that you started young. And you were pretty green. And as you met more and more patients, you learned more and more about the art, not so much the science, but the art side of being a physician.
Yes, you're absolutely right. Like Arthur Horowitz of Yale said that you think you're very smart until you go at the bedside. And so that I learned because I kind of mentioned in our connected lives, is that once I left Houston, I thought that I am up to date with the journals, I'm up to date with this and that, so I can solve anything. And then as soon as I found something a little unusual, then I knew I really didn't know as much as I thought. And so those are the things you learn as time goes, So yes, you're right. And that's one of the reasons, if I may say so, writing our connected lives, caring for cancer patients in rural Texas, is that I thought that perhaps I've gained some insights and some knowledge from my patients, interacting with them all those years, and how they are about life and living, how they have conducted their life, daily life, despite the cancer and the treatment and sickness associated with both cancer and the treatment, especially when you did not have good anti-nausea medications and all that before. So my idea was that I hope I can put it together. Perhaps others will gain some insight from my patient's experience and possibly my own experience. Remember that the subtitle says rural patients, but really cancer patients suffer the same way everywhere. It's same or similar ways everywhere. Only some more or some less, depending on their kind of cancer they have and their means and support. Otherwise, pretty much the same everywhere. I just happen to practice in West Texas, and that's why I wrote the stories of the patients of West Texas. But it could apply to any patient anywhere whether LA or New York or Boston or Houston?
I was recently speaking with one of my patients, and we were navigating the difficulty of engaging with practitioners and being a knowledgeable member, like that the patient themselves have to have a lot of self-efficacy. They have to advocate for themselves. They have to be very good sort of producers of their illness and ensure that they are checking all the boxes and they're showing up and they're, listening, but they're also doing as much of their own sort of self-study as possible. And we were talking about the difficulty that comes with disagreements when there's a sort of evidence-based approach to treating a cancer. And the patient says, I don't want to do that anymore, or I'm not willing to do that many sessions, or I cannot tolerate these side effects anymore. Can we do something different? And the pressure on the practitioner to find that balance between, well, this is protocol, and if I don't do this, I can't guarantee, versus I hear you and I hear that this is really tough. Let's see if we can't find another solution. And I'm curious your take on that interplay between art and science when it comes to cancer treatment, because it's not an exact science, is it?
Not at all, not at all. In particular, chemotherapy and all that. Chemotherapy, I don't mean to be negative, it's an imperfect treatment because you are giving a treatment that's supposed to kill the cancer cells. But on the way, it also kills the normal cells too. Luckily, normal cells grow back uh, and help you to go on and give you more treatments and get into remission. But in the beginning, you go through a lot. Yes, every person is different, as you know, since you're a psychologist. And every cancer, even breast cancer, for example, 5 different women have a 5 different temperament. And then, so you have to understand each patient. And simply going by the book doesn't always work, especially in my setting when people have to travel a lot and do this. So you try to do protocol 5 days daily for every 3 weeks or every weekly treatment or every 2 weeks treatment, every monthly treatment. So you try to adjust the best you can without compromising the treatment. To answer your question, yes, as you go along, you learn each patient is different and their circumstances is different. I've always been very interested in patients' inner lives, and that takes away a lot of your time, but I've always been very interested in that. And in your trainings, and you've been to training too, you you kind of rotate from place to place to place to place to ward so much that pretty soon patients become a blur, and you are kind of too busy finishing your daily work. So one thing that I learned coming to West Texas, and there are some difficulties too, so that you become more intimate with patients and their families, and then you see them, here and there, and they sort of become part of your life in a way. You can't just simply go to the office and come home and you don't see them anymore. You go to grocery store here and there and you see some of the family members or you see some of the patients or their loved ones and you talk to each other. So that kind of gives you a lot of insight into people too. And then the lot of times, at least many times, I've seen people what will come to doctor's office say something. They want to be right to the doctor, and they try so hard. But then when you're out of the office and in different circumstances, they're simply more relaxed and say things that they didn't exactly tell you in the office. It doesn't mean that they were hiding or misleading you. Circumstances sometimes do that to people, as that uh, like one of my patients told me, you don't exactly take care of high blood. We're a cancer doctor because so she didn't like some kind of wallpaper I had or a carpet. He said that you need to have more cheerful place. Okay. So, so that's the first patient, yeah, Clara Anderson, very outspoken. And those things kind of teach you something. You might say, lady, why do you worry about that? You came here for a serious problem. You worry about it. Why do you worry about my carpet and wallpaper? Okay. But that's not necessarily so. They watch things, they see you, what you do, don't do. Most people, um, they're understanding, but they have their feelings too, just like, you have to deal with them as a psychologist. So those two, yes, you gain insight and do the best you can from there.
Mhm. Yeah, and adjust and adapt and learn, I always say when people ask me, "Oh, how do you do what you do? Your job sounds so hard, it sounds so heavy, you deal with death all the time." Um, I feel like when people have that perspective, there's something they just don't see because, yeah, okay, sometimes it's hard, but it is very few people in this world can say, "I get so much meaning out of my work. I grow every day at work." And there is so much depth and connection in the work that I do. And ultimately, I am being 100% authentic when I say that I think I get more out of my sessions with my patients than they do. Like, I feel very lucky that I get to learn from my patients so many life lessons. And in a way, it's almost unfair because at least right now, I don't have cancer. I get to learn their perspectives the easy way in a lot of ways while they're learning them the hard way.
I wholeheartedly agree with you. Definitely do. I feel kind of same way. That's one reason that, if I may add, is that I'm so much for medical humanities. Like I said, when I started medical humanities, I started with Ward Number 6 of Chekhov. He's one of my most favorite writers.
Love
And
that book.
yeah,
Yeah.
Ward Number 6, this is a psychiatric ward, and patients get beaten up by a sadistic orderly. And the director, he came with idealistic views and then pretty much said, "Well, this is the way things are. What can I do?" And then, by quirk of fate, he became patient in his own ward. And then air orderly kicked him in his back and hit him in the face. He says, "Do you know I was the director in this place?" He says, "No, you are a patient. You get the same treatment everybody else does." So before he became unconscious, that twilight zone, he says, "How could I have ignored it for 20 years? My patients have suffered like this. And I did not notice it, or I didn't do anything about it. I did not protest. I did not I did not try to rectify it." So when the students read that story, they think twice. What would happen if I was a patient? Or if I were a patient? And that gives you a lot of insight into it. And then one of the poems that quoted is the Raymond Carver, What the Doctor Said. And again, the doctor and patient both struggling to convey the difficulties of the diagnosis and the treatment. So, like Carver died, at 50, so lung cancer with metastasis, and he was very fond of Chekhov too. So Chekhov died at 44 with tuberculosis. So he coughed out blood because of TB, and Carver coughed out blood because of lung cancer. So doctor finally says, "I wish I had a better news to give, but I don't." But then said that, basically saying, "Are you spiritual? Do you go to the forest? Do you look at the waterfalls? This and that." In other words, he does not have any answer for science. Science cannot answer your anguish, your inner difficulties. You need science, of course. That is the basis of medicine. So finally, the patient says that habit is so strong that I just thanked him and left. I did not want to know anymore. So that is the thing. I think medical humanities gives you a certain amount of insight, arts and literature, poetry, to understand people, understand their inner lives. At least that's what I feel. And most medical schools now, they're doing it. Like one I work with, the Center for Medical Ethics and Humanities San Antonio. We have that, teaching medical humanities and ethics from the start, at least the fourth year and fourth year medical students, and see what happens. And I feel, and also others feel too, my colleagues and others, that they probably gain a lot out of it besides just reading the science or studying the science. I know that with the modern life, that you only have so much time, you only have so much stamina, and so adding medical humanities another burden. You don't have to, you just, in a measured basis, I think it does a lot of good.
Absolutely. Yeah, I fully agree with that. And I think we've all seen the consequences when somebody is resistant to that kind of training, or they didn't have the opportunity to have it, or for whatever reason, they're not prioritizing that sort of patient-centered approach, that humanistic approach. And we've seen the difficulties. I've observed it, when a patient and a physician are just speaking past one another and they're just not connecting. And it affects treatment. It ultimately affects the patient's well-being in a tangible way.
Hmm. I agree with that. That's one of the reasons that I feel like medical humanities will help. And especially I'm worried, Kara, that AI is coming on, okay? And if you get, obviously we need technology, but in the end we have to remember that we're taking care of human beings, just like you and I do. So if we get away completely out of humanities, I have a problem that patients will think that's another machine we are trying to fix, not a human being taking care. I'm not trying to exaggerate, that's my feeling. So that's why I feel like that to be grounded and to be empathetic and to be sensitive. Not only the obviously teachers have a lot to do with it, mentors. You learn how to medical humanities and ethics, and that's one of the things that few of the things that I address in my book, Our Connected Lives. And I the interesting thing is that I really, you remember Susan Sontag's quote. She said that when you are born, we are born with two citizenships, the citizenship of the sick and the citizenship of the well. So eventually in life, you will be citizens, one or the other. So we are all connected. So I feel like that uh, we need to understand not only cancer, even life and living, understand that human beings are different and we have to understand each other to get along and to take care of them, and then understand their idiosyncrasies and quirks. We all have that. So I hope that my book addresses some of that, and that's one of the reasons I put it together and selected patients that they make points that uh, I try to say that, and this is the truth too. You know that, Kara, that uh, you have problem with, say, family, children, wife, spouse, insurance, money, all those things. Just because you have cancer, they don't go away. And my chemotherapy, my radiation, my chemotherapy, my surgery, they don't take those things away, do they?
No, sometimes they actually contribute to that.
Correct. So
Yeah.
we have to remember that they just didn't come for their cancer. They have other problems too. Obviously, you're not going to be able to solve all of them, but you have to understand that they have other problems besides the cancer and the chemotherapy. So that's some of the things that I address in Our Connected Lives. I do feel like we're all connected, and like just like Sontag said, that we are citizens of two worlds, citizens of the sick and citizens of the well. It's just a matter of time when you're citizen of one or the other.
Absolutely. Yeah. And we are all going to die. And I think that, this is something that many of us have come up with very extravagant mental gymnastics to avoid that truth, that reality. But this mortality is a big part of working in the cancer space. Obviously, we are all doing what we can to either extend life or to improve quality of the life that is left. But very often it does come back down to that realization that if not from this, from something, and if not now, eventually. And grappling with mortality, I think, is a big part of the process of living with cancer and eventually, or unfortunately, sometimes dying of cancer.
You're right. That's one of the things I also address in Our Connected Lives is that students and trainees need to know, residents and fellows, that taking care of the terminal patient, taking care of the dying, and taking care of the end of life care patients are just as important as necessary as taking care of other patients. See, when I was trained, even in these big places, whether in Dhaka, New York, and Houston, we hardly talked about the end of life care. Our main aim was to uh, prolong life at any cost. And not only that, we didn't think a whole lot about quality of life either 50, 60 years ago. And so end of life care is much better than used to be with hospice and other organizations. But it was not, even in that, if you look at the old textbook, there is no chapter on end of life care or anything like that. Our
Yeah, which
aim is
makes
cure
no
disease. Yeah,
sense.
correct. So
Because
now,
not everybody goes to hospice. Some people continue active treatment right until the end, which means it's the oncologist and the palliative care physician and the rest of the team that's offering end of life care.
absolutely. So those are the things that I also address in our connected lives, that this is important that we improve our end of life care and other aspects of the care in general, not just try to cure. And quality of life matters too, quality of life, end of life care. And you're right that we're all end up eventually going to be there at the end of life.
And in some ways, dying from cancer, as strange as it might sound, many of my patients have taught me that dying from cancer can be a gift. It can be a kindness. We're all going to die, but it's a special circumstance when you know that it's coming and you have time to plan. And many people don't have that opportunity. They're gone before they realize it. They're gone before they can, close or end relationships appropriately, before they can make decisions about their legacy. But that is, I know, as crazy as it sounds, because it's a terrible thing, but it's a big silver lining that a lot of patients have taught me that they had, was the knowledge that, I've got about a year at this point. Maybe it'll be more, maybe it'll be less, but I'm going to use that time.
Absolutely. That's what I'm saying, that I learned so much from my patients and I hope that they learn something out of me. But these are stories of the patients, and you can read weighty tome on all kinds of things in cancer. But I think that I feel like the readers and the students and the fellows and residents, perhaps the junior faculty members, they'll gain some out of this because I try to do cancer biology and through the stories of the patients. So I'm hoping that that would be more accessible, to general readers also. And that's one of the aims I had for our connected lives and still is. So I hope that it succeeds in that sense. Uh, and then there are other things. For example, I give you an anecdote. This Mrs. Cooper, that 87-year-old patient that ovarian cancer, when uh, she was quite sick, and that's another ethical dilemma because 85 plus years are the oldest, fastest growing population in the country, and we'll run into more gray areas, and we need to decide right now, think right now, how to manage that age group, how much to do, not to do, and what to tell and not to tell, and things like that. Obviously, you have to be honest with the patient. So when she was getting sicker, her daughter didn't want her to stay in the country. She's a farmer's wife, and her husband died, and she doesn't want to leave the country. So finally said Dr. Rahman, if you tell her, she will listen to you because she listens to your advice. And you know how sometimes mothers are, they wouldn't pay attention to the daughters sometimes. And so she looked at me and she says, Dr. Rahman, do you think dying in the town is better than dying in the country? I had no answer. I'm supposed to be a smart oncologist and I'm supposed to be, experienced doctor. How do you answer that kind of question? And she did stay there, eventually died in her farmhouse.
It is amazing, the power, and I think that's something that many young providers don't really grapple with enough. But the power of our words, that there is an implicit expertise and an implicit respect for certain types of expertise in our culture, that we, as those who are dealing with our own imposter syndrome and dealing with our own discomforts, don't often stop and take a breath and say, when I say something to a patient, many of them see it as gospel, and I have to be very careful with how I choose my words.
Yeah, that's the art part of the medicine, and it comes with practice. But also, I should say that, and with obviously, when you get a little older, people will say that you give pontificate on a lot of things. But I've been trained some very, very caring teachers and professors and all that. But believe me, Kar, I've also seen people, they just regurgitate textbooks and regurgitate journals and all that. They're quite up to date and latest. But uh, that's about it, and they don't talk about bedside medicine and all that too much. And so obviously, if you're trained under that atmosphere, you kind of carry on when you become a practitioner yourself. So I think that responsibility not only belongs to the trainees, the fellows, residents, interns, whoever that is. It also, I think teachers have to take responsibility too. What do we do with our students, with our fellows, with our residents? Do we just simply teach them, science and leave it at that, and then rest of it is their business, what they do, don't do when they get out of here? So I feel like that we do need emphasis from the medical schools and institutions to not to completely forget the bedside medicine. Like my mentor, Professor Rob, he was in Dhaka, SM Rob, he said that your healing begins with the arrival, with your empathy for the patients and your demeanor at the bedside. That's where the healing begins. And I remembered that despite all my defects and failings, that hopefully I could do that at least most of the time, if not all the time.
I'd love to ask you something that's maybe a little bit meta, but I think this is a perfect segue into that. I often see culturally in medicine, and I did not come up through medicine. I came up through psychology, right? I came up through a PhD program. Um, but I often see in medicine a culture of sort of, or a rhetoric that says the best way to care for yourself in when you're working with very sick patients is to have a certain level of professional detachment. And my view has always been, no, the best way to care for yourself is to be as invested as is healthy and comfortable for you, and then give yourself a lot of space and time for self-care. It's have a lot of work-life balance. It's do the rituals when you lose a patient, allow yourself to grieve. I very worry about the instruction to be somehow professionally distant or detached from your patients, because I think it can lead to the very bedside manner, the very issues with bedside manner that you've been discussing. And I'm curious what your take is on that.
Yes, I agree with that for the most part because patients sense it, when you're detached. They know that, and they get, like hope is an important part of care. You don't want to give false hope, but when you are detached, patients thinks that, doctor has given up. So if patient feels doctor has given up, patient is going to give up too, correct? So not, you have to have some mental discipline and it comes in time that if, for example, you don't want to carry one patient's problem to the next patient. So you have to stay involved and attached. At the same time, have a certain amount of mental discipline, and then go to the next patient. Then as good as you can, as cheerful as you can. Cannot always be perfect, but do the best you can. I think, but I disagree that you get detached and then keep a distance. It really doesn't help the doctor or the patient either, because then how far distance you want to go? If you go too far, then you're not going to take care of patient at all, because terminal patients are a common factor in cancer. Remember that we still, and again, it's not a negative, just a fact. It's look at the most of the metastatic cancers we don't cure. Lung cancer or melanoma. Some of the cancer do very well, like breast cancer. We kind of make it a chronic disease. Metastatic cancer can live for a long time. Ovarian cancer, uh, cancers like that. But a lot of metastatic cancers that are incurable. So those patients are going to need your care, need your attention, and need your empathy, and need your feeling. to survive and to go on. And if they become hopeless or in despair, you can't always avoid despair, but at least do the best you can that they can come out of it and do the best they can, just like you do. Keep out of despair as much as you can and do the best you can. So it's a kind of a balance. Yes, there is a balance, but balance is not necessarily getting completely detached. I don't agree with that.
Yeah, I agree, and I like the point that you made that it's not just bad for the patient, I think it's bad for the practitioner. I think that when somebody feels that they are protecting themselves by being somewhat cold and professionally distant, you're right, not only can the patient fully see that and feel and then now they don't feel warmth or connection to their practitioner, but also I think it bleeds into other aspects of the practitioner's life. That this what's often viewed, I think, as a skill of like cool, cold detachment is actually just avoidance. It's really denial and avoidance, and it comes out in other ways.
But that's that's why I put that title, "Our Connected Lives." When you're taking care of people, when we are all connected anyway, so you our connected lives, patient and the doctor together. I'm not saying that we're always perfect or going to do everything right or you're going to be no mistakes, this and that, nothing like that. But you don't want to do intentional detachment because that really comes out and patients sense it quite well. You don't have to be, highly educated or anything. Anyone can feel it, whether you're interested in that person or you're not interested in that person.
Yeah. And I think there's this fear, especially among young practitioners, that if they become, if they show their feelings, that it's going to destroy the relationship. But I very firmly believe that if you're erring on one side or the other, err on the side of empathy. And if you cry in that room with the patient, you will recover from that and they will recover from that. And sometimes that's appropriate. Sometimes it's not. Obviously, sometimes you don't want to telegraph to the patient that you can't hold space for them. You need to be able to hold space for your patients. But if tears flow out of your cheeks when you're delivering bad news, I think that that is much more beneficial, or maybe I should word it this way, far less detrimental to the patient than if you look like a robot.
You're absolutely right. I mean, I don't mean to sound like I'm any better than any other doctor, but it has happened to me many, many times in the, especially first few years. But then you never get completely used to it, but you know how to deal with and handle it, as time goes and as you gain more experience. And then and that actually training has also a lot to do with that too, because your teachers are interested in people. You sense that when you are, making rounds with them, but versus teacher just teaching you, and patient is a kind of a necessary vehicle to teach, not necessarily to treat. Uh, I don't mean to be pompous about it. I think you understand what I'm trying to say. So if the teacher says that he or she is not only taking care of patient, at the same time, patient is giving us a chance to learn. And if we have that kind of attitude, then we can do just much better than we simply make bed to bed and make round. This patient is lung cancer, this patient is breast cancer, this is lymphoma, that's Hodgkin's disease, and go on and just recite facts and figures and how to treat them and cure them or not cure them, versus taking that this patient is here to get our attention, to get our care, and also giving us a chance to learn. And I think the young doctors, students, medical students, they pick up on that.
Absolutely. It reminds me of some conversations I've had with some individuals who work in ICU or especially in neuro ICU, where it's not uncommon for patients to be intubated and sedated or in like actually in a coma, unconscious. And there can be a culture of treating the patient like they are not alive, talking about the patient as if they are not there, performing exams on the patient without talking the patient through what you're doing. Maybe they can't respond to you, but there is a chance that they can hear you. And there is a chance that when they come out of their ICU stay, that they will have a lot of trauma from this. And for some reason, I think culturally, that hasn't quite shifted in medicine.
I think that we're having more understanding, and I want to go back to the same thing again just for a minute. Uh, you grew up in Plano. Have you heard a college named Austin College in Sherman, Texas? It's a first-rate liberal arts college. When I was an active trustee for 12 years, now I'm a senior trustee. The one of the reasons I felt honored that they asked me to be a trustee is that I believe in humanities strongly, even though I'm a doctor. And that's part of the reason that uh, I became part of a liberal arts college. And that's one. And the second is that they kind of intersect. In other words, humanities and science, they can actually come together. We don't have to make a big feature or big deal out of it. It can be reasonably seamless. Poetry, literature, and all that can teach you quite a bit about human beings, their illness. Like if you read Tolstoy's Death of Ivan Ilyich, you really know how a powerful person that slowly becomes so invalid that nobody really wants to be around him, and his anguish and all that. So I feel like that those things have a place, like word number six, and I can give you a lot of other examples, but those two just come to mind. And I'm sure you are familiar with them. So liberal arts education, uh, in the sense, you don't have to go to liberal arts college, but it can be taught in the medical school uh, in a measured way, and that can be effective in a selective manner.
Yeah, I agree. I agree with that wholly. And you're right, it's very difficult with modern managed care and the pressures and demands on medical students, on young residents, and then even on attending physicians to, you know, keep the patient contact time down and see as many patients as possible and ensure that they're billing appropriately and ensure that they're, checking all the boxes. And at the same time, why did you get into this to begin with? What really is the purpose of engaging as a physician? And especially, in this case, a cancer physician. You know, what do you get from this work and what do you feel that you're giving to your patients? And if that's not front and center every single day, I do sometimes wonder where we've lost the plot.
I think a lot of reasons, to some extent, is that the teaching method and the second demands of, modern life become kind of too cluttered. And then I think getting away more and more at the humanities education. Again, I come back to that. And and then you are right. Like one of my friends, gynecologist, very first class one, she told me one day, said, Fazlur, some of these computer systems in the hospitals are geared more for reimbursement than helping patients. So that's a very telling comment. Like there's a big push for AI. I understand that it will help make it efficient, this and that. But my question is this: the time that you save, is it just going to be help the administrative aspect? Is it going to help the patient or what? Where are you going to spend the time that you save by all this technology you bring in? Correct? You are going to spend that time with the patient, or you're going to just spend it uh, something else.
Or are you going to squeeze in yet another consult, yet another
Another concept.
patient?
Exactly,
Yeah.
exactly. There are clinics I know personally that's what they do. That you can only have 10 minutes, or in fact, the one time I called it, and I don't want to name anybody or anything, and I'm sure I shared my share of mistakes too. A doctor's office said that for a new patient we have 10 minutes, and then after that we have another time later talk to this and that. The 10 minutes for a new patient is nothing.
No, it's
So
nothing. And
no,
there are systems in place now. I see it all the time where you go to a specialist and you can only have one chief complaint. And if there's something else you need to talk about, you have to make a separate appointment.
correct, correct.
That's bananas.
Well, I seen that, like you're talking about when West Texas, that's what happened. Like, when I was trained in whether in New York or Houston, you got every little problem, you are sent to a specialist, correct? Uh, whether oncology or cardiology doesn't matter. Here, I didn't have anybody to send to anybody. So I did the best I could. And that also gave me quite a bit of insight from the patients also. And that kind of helped, I guess, that to be, hey, let me tell you something. One time I was complaining, I had an ankle fracture in a hiking accident, and I was complaining too much. So then Ara, that is my wife, she says, why don't you think one of your patients? Why are you whining like that? And that took care of it.
Yeah, I mean, it's very humbling to be on the other side of that desk for sure. And I think we will all be there at some point if we haven't already been. And I think that it's a meaningful experience for any practitioner to be sitting in that very seat that their patients sit in.
I have a chapter in the book, Our Connected Lives, Empathy Matters in Medicine, that addresses that, me as a patient.
Yeah, if you don't take from it the lessons that it's offering to you, that's a wasted opportunity for sure. So I want to ask you just here before we finish up the hour. We've been talking quite a lot about the experience of being a physician in West Texas and rural Texas, the experience of learning from your patients, some wisdom that you have gained over the years that can be passed on to young medical students, to residents and fellows. What about flipping the script? Most of the people listening will not be physicians. Some of them may be, and hopefully they can take a lot from that. But many of the people listening will be or have been patients. And so I'm curious from you if there are any big takeaways, any wisdom, any knowledge that you might like to share with a patient who may one day find themselves having to navigate the oncology world, waking up needing a biopsy and having to start that whole process of cancer diagnosis and treatment. Is there anything that you would like to share with them?
Yeah, look, I think that when you go to the doctor, the first and foremost thing that, be prepared as much as you can, know about the subject. I mean, not everybody can know. And the second is that, remember, stay positive until somebody tells you you have this kind of cancer or this prognosis. Don't take it all negative. For example, breast biopsy. 80% of the breast biopsy are negative for breast cancer, okay? Only 20% positive. So those are positive things. And the second thing is that I guess for a patient, try to understand the doctor also, see where he or she is coming from, give a try. I don't mean to say that they have to be a psychologist like you, but just try to understand the doctor, and that helps a lot. And they build a confidence between the doctors and patients. And if there is that's the first one. The second one is that if you're uncomfortable about something about a doctor, you need to at least, you don't have to pick up a argument. Explain to him, doctor, this is what I didn't like particularly. And most doctors, at least I have seen, they will try to mend their manners. There is a patient like I gave you in the book that says that the doctor told him not to go to the oil field and work, but he couldn't help it because he has to keep his job, and he got infection, sinus infection, pretty bad. He says that, you don't pay attention to the doctor, that's your problem. So, but the patient probably could, if he could, understand why the doctor said that. On the other hand, it's more responsibility of the doctor than the patient. Why did the patient could not keep the advice? Simply because he couldn't, he has to live too, make a living. To answer your question more precisely, just try to understand doctor and stay positive. And then always, if possible, always take someone with you, especially in cancer patients. There are good studies shows that patients don't remember, because when you're under pressure and under distress, having the diagnosis of cancer is bad enough, and then you go through all this diagnosis, prognosis, laboratory, people are throwing, nurses, doctors, all the information. So always try to take a person with you, a family member or close friend if you don't have a family member, so that if you don't remember, that person will remember. I always made it a point that please always bring someone with you, someone you trust, family member or others. Occasionally, and again, to answer your question, sometimes family members don't get along well, so they don't want to bring somebody from the family, but at least bring a friend or someone to. I'm talking about especially cancer patients, chemotherapy patients, not necessarily ordinary problems, which most of us can handle easily.
Right. Yeah, I think that's very, very good advice. Gosh, I feel like this has been such an illuminating conversation. There's so much more in the book, everybody. It's called Our Connected Lives: Caring for Cancer Patients in Rural Texas by Dr. Fazlur Rahman. Fazlur, thank you so much for being here with us.
Thank you for having me, Kara. I really enjoyed talking to you.
As did I. And thank you again to everybody listening for coming back week after week. I'm really looking forward to the next time we all get together to talk nearly.